Thank you very much. It's an honor to be with my erudite colleagues. I've changed the title to I See Double Images. And although I am very conflicted, I have no conflicts with this talk. This is a case of a 65-year-old man who has been complaining of double vision for 2 months. His medical history is significant for diabetes mellitus, hypertension, and hypothyroidism. And he has intermittent diplopia with monocular or binocular viewing. He has no headache, he has no pain, he has no ptosis. And on exam, his vision is normal. His pupils are normally reactive, without afferent pupillary defects. He has some dry eye findings on slit lamp examination, including some punctate epitheliopathy inferiorly. And he has a few microaneurysms on his fundus exam, but otherwise it's a normal exam. On cover testing, he has an exophoria of 8 prism diopters at near and an exophoria of 4 that is concomitant in all directions of gaze. And in trying to characterize his diplopia a little bit more, it doesn't resolve with pinhole. And he says, "I see 2 of you, doctor." And he says, you look the same in both images. In other words, this is not a ghost image that he is seeing. And the second image fades about 10 seconds later. So here's the question for you. Among the many things you could do, I've listed 4. And of those 4, which of them would be the most helpful to you? Note that even though this is the neuro-op session, I didn't include MRI scan. Go ahead and vote on this. Perimetry, drug screening, corneal topography, psychiatry consultation.
Can I ask you a question mark?
Yeah.
Oh, I like that question mark. That's really good. You get that all the time?
Oh, that's pretty interesting spread. Okay. Go ahead.
Is his monocular double vision the same identically in both eyes?
That is such an astute question.
Is it?
It is. The answer is yes.
Is it sometimes triplopia or?
No.
Okay. Color vision?
Excuse me.
Color vision?
What is it?
Is it normal color vision?
His color vision is normal.
Can he recognize faces?
Yes.
Anyway, what we're fooling around with here is something I think that we're not supposed to teach the children.
This is the last one of this section.
Yeah, exactly.
Right?
So if you have monocular diplopia, 99.9% of the time, it's yours. It's a refractive error, or cornea shaped a funny way, dry eye, maybe even a little wrinkle in the retina. It's not the neurologist. But what he's describing here is the kind of monocular double vision or triple vision, as Mike was asking about, when it's identical in both eyes and it doesn't clear with a pinhole. There are rare reports of cerebral polyopia, due usually to parietal occipital lesions, rarely to migraine phenomena if it's transient. And I guess that's where, what you would choose in this case would be perimetry, because you'll want to see if there is a lesion that, a field defect that localizes to the retrochiasmal visual pathways.
So that's what you voted for.
Well, only because I'm in this setting. You know, the reality
this is a neuro-op session, not a
This is a neuro-op
session.
But again, it's not something I like to teach the residents. I don't want them to be thinking that monocular diplopia is a brain problem, but it rarely can be.
The rest of you concur.
Yeah, I would definitely get a field, but I think, you know, if this is persistent visual perseveration, I mean, there are some drugs that can cause that too, or at least are associated with it.
It was LSD in his past.
Yeah, he did say in the history that the second image fades away after a period of time. Does that mean anything to you guys?
Well, I mean, maybe it's more like the visual perseveration that's, you know, temporary.
Okay, we'll move on. So, yeah, the correct answer is a visual field. And what you can see here is a non-congruous left inferior quadrant anopia. And that should have some localizing value to most of us. And that would be in the parietal lobe. So the next step would be an MRI scan. And lo and behold, there is a tumor in the right parietal lobe, which is hard to miss. So we have any more? This is obviously very short because this is slam dunk for these guys, but do you have any more comments?
This is really rare, folks. This should be on the bottom of the diagnostic tree, but
I am last.
Can we go back to the visual field?
Yeah.
Question from the audience, is that visual field truly abnormal? If you could walk us through it.
I think
Well, it's hard to see the numbers, but, you know, in that left inferior quadrant, it looks like there's some double-digit numbers in there.
That's true.
So,
And honestly, when this happens, I would think more times than not, you don't actually have a field defect because it's really, especially if it's in the parietal cortex. Remember, the parietal lobe has the radiations in the white matter, and you can certainly have no visual field defect. You may have other higher cortical functions be abnormal, and we have a whole battery of those that you can look for, some of which the visual spatial ones are more likely to be seen in parietal lobe lesions than in deeper lesions. So prosopagnosia and color vision problems are going to be more inferior than parietal.
Mark, did you do optokinetic nystagmus testing on this patient?
Embarrassingly, no.
Just to see, because if he had a parietal lesion, the OKN would be asymmetric.
That's correct, but no. Okay, so I'll move on, finish this up. Okay, so palinopsia. There's an excellent review that Andy Lee wrote a couple years ago that really summarized this whole thing. In that paper, it's broken down into two types of palinopsia, hallucinatory palinopsia, which is what this category would be, and illusory. So hallucinatory ones are where there's a definite image that is something that you just looked at or recently looked at can be perceived as a diplopic phenomenon, whereas the illusory ones are problems with visual sensory transitory phenomena like trails and light streaks and things like that. That's not what we're talking here, that's going to confuse you in terms of the differential diagnosis of diplopia. So in this case, this is what we're talking about is this first form, which is the hallucinatory type. And the first thing is it is clearly distinct from retinal after images. These are not negative images at all. These are crystal clear, identical to the object of regard. They appear very realistic, but they are superimposed on the visual scene. And even if you change your gaze from what you were looking at, from the doctor you were looking at, you still see that second doctor superimposed on other parts of the exam room as you look around. And they often occur in the area where there is the visual field defect, the second image does. And they may occur immediately upon viewing the object, or they may occur up to 2 minutes later. And they often will persist for seconds to minutes, as in this case. You may also have them where you see a part of the original object superimposed on other objects appropriately. So you may see somebody with a hat, and then subsequently the people you look at after that all have the same hat on their head. That's fun. It also may record, it may not be a fixed image, it may actually be an activity, an action of some sort, lasting over a couple of seconds or more, where you've seen a movement of an arm, and that same arm keeps moving over and over again. So it's like a snippet of a video recording. And these are almost always caused by a lesion within the posterior visual pathway, including strokes, tumors, infections, cerebral dysplasia, aneurysms, AVMs, things like that. There are other causes, so they have been reported with TIAs, they have been reported with seizures, and they have rarely been reported with migraines. And that is all I have to say. Thank you very much.
Any more comments from anyone about palinopsia in general, with or without double vision?
Yeah, I wasn't joking about actually the LSD.
Right,
And,
right.
and that can occur even 20 years later, and
Right.
even having only tried it once. I don't know this from personal experience.
you didn't
I promise
inhale.
you, but I have seen that.
So there's, with drugs and metabolic disorders and things like that, both licit and illicit drugs, you can have palinopsia. Most often it is the so-called illusory form of palinopsia, where it's not a fixed image that's repeated. It's not confused for diplopia. And you're right, it occurs years later, but it is something like trails and stuff like that that may occur many, many years later. But it is really different, and it's not usually confused with diplopia. Thank you.